So I started my lecture on, what was it, the respiratory system with this same photo. And that is it's just as applicable now. So these same sort of models. I left this old crusty picture in there because I have a particular fondness for this that plaque. But the point being that the modern equivalent of that model is the one that Katie has over there. But the point being that these models here are going to be the best ones for pointing out any of the anatomy in the upper reaches of the GI tract. So that would be the oral cavity, the esophagus. Let's look at the oral cavity, shall we? All right. So your lips are called the labia, the upper and superior and inferior oral labia. And the cheek is called the bucca. We've covered those terms, I think, at the beginning of the year or the beginning of the semester. And then there's the superior and inferior dental arcades, which are just your row of teeth. That's what we call them, the dental arcades. I used to go through all the teeth and identify each of the types, but it's not really worth it now to do that. But I'm going to point out a few salient features. So there is this, behind the second to last molar, there is this little opening there for the parotid duct. We'll see a better picture of the parotid duct, and I'll talk about the parotid gland in lecture today. But essentially, this is one of three ways that saliva gets into your mouth through the parotid duct, and it's meant to serve the posterior portion of we've already pointed out in the past the palatine tonsil. I don't have it. Took the label off there. But a lot of these structures that I took the labels off of, we already know. This would be the auditory tube up in the nasal pharynx. The oral pharynx is the portion of the pharynx that is just posterior to the oral cavity. And this opening from the oral cavity into the pharynx is what we call the fauces. Anything else on this slide that is well, we have the hard palate, the anterior 2/3 of which is made of the maxilla, and the posterior 1/3 made of the palatine bones. But then the hard palate itself is only the anterior 2/3 of the entire palate. The posterior margin of the palate is called the soft palate, and it's all soft tissue connected to that mouth and separate the oral cavity. We'll see a better, so the uvula, we'll see a better picture of this in just a moment. So a lot of this stuff is best identified on this model right here that is at the end of this bench. So now, looking in the mouth, there we can see the fauces. Here's the uvula hanging down. The fauces is this margin, this opening between the oral cavity and the oral pharynx, which would be posterior to it. This person is sticking their tongue off to the side, and we can see this little strip of tissue called the lingual, meaning tongue, lingual frenulum. Frenulum just means a tendinous strap that is connecting some tissue down the midline. So there's different frenula. There are superior and inferior labial frenula that you see here. here. But like, so for example, people with really large, prominent superior labial frenula end up being like, you guys, is David Letterman too far behind for your time? You guys know David Letterman? Big gap in his teeth there. Who else has it? But it's, yeah, what? Yeah. Yeah. Did they do anything to fix it? Okay, well, braces, sometimes they'll do braces, but in real extreme cases, you can have them when a person's a child, they'll just snip it. It sounds radical, it's not that big of a deal, and it prevents that gap in your front from getting large. The lingual frenula, if it helps anchor the tongue into the mouth, there is that dubious rock and roller, probably a sexual harasser, Gene, what's his name? Simmons from Kiss, that guy, the moldy oldie from the 70s. He's one of the guys with the makeup on his face. He actually had his lingual frenulum cut so that he could stick his tongue all, if you see those pictures with his tongue hanging out down past his chin, that's the reason he can do that. What people will do for rock and roll, justify anything he does. But on either side of the lingual frenulum, you can see the two openings to the submandibular ducts. So the submandibular gland are some salivary glands that live right underneath the mandible. We'll see a better picture of them in lecture. But this is the second way that saliva can get into the mouth. And if you look in a mirror, if you've ever lifted your tongue and looked at the weird stuff under there, you'll probably have noticed those little puncta for the submandibular ducts. All right, so here's a better picture of the salivary glands. We have the parotid gland. It's this gland over here. It's on the just above the angle of your jaw, kind of back by your ear. And it's the one that sort of shivers when you eat a lemon or whatever. It happens to me. My parotid gland kind of squeaks. But you see this duct that transmits the saliva to the parotid gland to the back of the mouth. And then we have the submandibular gland that lives right underneath the angle of the jaw. So this is on the surface, right up here underneath the skin, and submandibular gland is the angle of the jaw. And then right underneath the tongue is the sublingual gland. Sublingual gland also produces saliva, and it has the whole network of ducts that open up along the lateral margins of the root of the tongue into the oral cavity. All right. So all three of these glands actually make the saliva that each of them makes is a little bit different. It's a little bit different, and I'll briefly touch upon that in lecture. Is there anything else here? I don't think so. You can see the lingual frenulum. Okay. So then the salivary, or the taste buds. So this model is, I don't know. Oh, there it is. Meryl's got it. So you can see this would be a papilla, a lingual papilla on the tongue. And there's a couple different types of papilla. These are what are called filiform here, these little ones, these larger papillas. And the large papilla, if we look at a cross-section of them, which is also on this model, embedded in the side, you're going to see the taste buds. And here's a blow-up of one of those. So if you look right along here, you see these little darker spots on that model. Those darker spots correspond to the taste buds. And in that, you can see the labeled line code. So within a taste bud, there's multiple sensory receptors, each with a different axon that is going to travel up to the gustatory centers in the brain. And it's labeled by color, giving a sort of matotopic map of taste, I guess. Say that. It's not quite the spatial map that we talked about earlier with Wilder Field's homunculus, but it's a map of taste in the brain, which is kind of a fun thing to think about. All right, so teeth. I do have a tooth model out here. Is it on the deck, or do they pack it away? Yeah, okay, great. So did somebody ask? Oh no, it was my high school class asked about teeth yesterday. They wanted to know. We were talking about epithelium, and I actually gave them some stuff that you guys didn't get. I talked about the embryology of ectoderm, endoderm, how. But he wanted to know if there were cells, and sort of. It's kind of like bone, but not exactly, because teeth are coated in, it is bone, but they're coated in this external layer, this cell-free layer of enamel, right? And enamel is very dense and hard material that gives the tooth its cutting surface or crushing surface. Beneath that enamel is the cellular layer here of the dentin. This is much more similar to dense bone. And then inside the dentin is what we call the pulp cavity. It's kind of like a marrow cavity, I guess, in your bone, except it doesn't have marrow in it. Pulp. And that pulp mostly consists of neurovascular bundles, little capillaries, nerve that innervate. Then all those neurovascular bundles descend through what's called the root canal. There's a canal that goes down through the root of the tooth. Okay, I guess I should have said there's a crown, a neck, and a root. Three regions of the tooth. The crown is the exposed part of the tooth. The neck is this transitional region where the enamel kind of peters out and the tooth begins to embed itself into the gingiva. Your gingiva is your gums. The little groove between the tooth and the gingiva is called the gingival sulcus. So sulcus we now see is a general term for any kind of divot or groove. The tooth itself is adhered to the substrate of the alveolar process, meaning the alveolar process is the hole into the mandible or maxilla that the tooth embeds itself. It adheres to it via this cementum. Cementum, it's this layer that, so the dentin transitions to being covered by enamel to outside of the gums to cementum on the inside, and then perforating the cementum and embedding itself, working itself into the periosteum of the alveolar process are these periodontal ligaments. There are these little ligaments that go from the dentin of the root and perforate that periosteum of the bone, your jaw, working. And that helps to keep the tooth sitting. There's probably no joint, no bone-to-bone surface in the body that's getting as much constant, intense pressure as chewing all the time. situated. Then at the end of the root, there's what's called the apical foramen. It's the exit point for the neurovascular bundle of the. Okay, so that's what a tooth looks like. Cool. So, yeah, the stuff on the bottom, incisor, cuspid, premolar, bicuspid, don't worry about that. Do you get it, or do you want me to point all this stuff out once again on this model? You guys get it? All right, so this is the model. Here's the dental arcade. I indicated I wasn't going to go through specifics of which teeth are what. All right, so leaving the mouth, traveling down the esophagus, we're going to go through, slide, it's not projecting, go through the esophageal hiatus. Esophageal hiatus. Should be in the list there, but ESOPHAGEAL, esophageal hiatus, HIATUS. Yeah.
Oh, why isn't it the esophageal?
Helium.
Helium? The word for opening.
Yeah, so we have been talking about hilum as the root of the maybe esophageal. Helium is right. That actually is ringing a bell, but I don't know. I've always known it as esophageal hiatus, just a hiatus point where the muscle tissue kind of diverges. And there's this aperture through which the esophagus is able to pass down to the stomach. Yeah, I don't know. We can do a little bit of. I don't think that helium. I think we've established. Hilum. I don't think that's it. It's esophageal. I'll have to double check. I don't want to take a firm stand on something I'm not. But anyways, we talked about the nasal cavity before, but here's the pharynx once again. Pharynx is the posterior aspect of it's the throat is what it is, I guess. There's the nasal pharynx that goes from the internal nares to the superior margin of the fauces. Then there's the oropharynx, which is fauces back, and then the laryngopharynx, portion of the pharynx that really terminates. This diagram's not perfect. It terminates at the level of the bifurcation between the esophagus and the larynx. Should get a better picture than that. All right, the stomach. Look at that ugly thing up there. That is a stomach that has been turned inside out. And it has been turned inside out so that we can see the rugae. The rugae. These rugae are the ridges, the big ridges that you would see on the inside of the stomach. Has anybody ever had tripe? I'm from Detroit. I go to there's a little Mexican taco tree pots there. That's right. You can see it. That's right. It's just cut up stomach. You really can clearly see the ridges. Okay, so let's break down the anatomy of the stomach. Esophagus comes in, and the first thing it hits is what's called the cardia, the heart of the stomach, cardia. And that's this portion right here. From the point of access of the esophagus superior, we're going to have this little bulge up here. It's called the fundus. Fundus. Usually fundus means, it's related to the word fundamental. It means the base of something, beginning of it. So on the stomach that Ellen has here, this would be fundus across here. Cardia would be right here. Then we transition from cardia into body. all of this is the body. And then as we begin to funnel down, this becomes called the pylorus. The pylorus communicates with the first bit of the small intestine called the duodenum via the pyloric sphincter. Has anyone heard of pyloric stenosis before? Pyloric stenosis is pyloric sphincter, or pyloric stenosis is a condition whereby infants, newborn babies, if you notice that your newborn baby is spitting up more than normal, it's not thriving, and it's vomiting a lot more than is typical. I mean, all babies vomit. They're trying to figure out how to get that thing going, get that GI tract up and running. But if it's like every meal they're throwing up, you may want to consider having the baby evaluated for pyloric stenosis. And this is essentially a pyloric sphincter that is overdeveloped or stenotic. It's not able to open up. The connective tissue ring around that sphincter is not able to release, and the gastric contents can't go that way. You gotta get out of there. So they go the other way. The baby barfs, I remember. The only reason I bring this up, actually, is because I remember I'm the oldest of 3 boys, and me and my brother, and then my youngest brother was not actually expected. He was an anticipated sibling. Came 10 years after me, so I was 10 years old and had this little brother, which was pretty fun. And he had pyloric stenosis, and I just remember he was so sweet, sitting in his high chair, barely able to sit, but he'd eat, get his food, and then he'd just sit there with his like cheeks bulged out like a chipmunk. And my mother would go up, I told her, you want a cup of something to drink, and bring him a cup, and I'd take the cup and just barf right into it. He was sitting there with his vomit in his mouth. He did it out. But pyloric stenosis, quick, easy laparoscopic surgery, done. No problem. He's a happy nurse practitioner, cardiac nurse practitioner in Florida right now. Okay, so, oh, wait a second. Was that everything? No, it wasn't everything. So there's a couple things I need to point out. A couple other things. There is a greater curvature to the stomach and a lesser curvature to the stomach. The lesser curvature is medial, and the greater curvature is lateral. That's going to be significant in the next slide when I talk about the omentum. But in the meantime, we'll talk about the muscle layers. There are, in the stomach, 3 muscle layers. In a lot of the GI tract, there's actually only 2, but in the stomach, there's 3. So we have this on the outside is the longitudinal muscle layer. And then the next one in, we have this circular muscle layer. So they run at 90 degrees to longitudinal, running along the course of the stomach, and a circular one inside. All right. And then in the stomach, in particular, there's this third layer of muscle that's the very most deep, and it's oblique. All right. So it runs at a 45-degree angle to both of them. All right. So we have this triple reinforcing muscle layer in the stomach. And essentially this is because in the rest of the GI tract, like the esophagus and the intestines, the longitudinal and circular layers, they're more than enough to create the peristalsis, that the muscle contractions that drive food along basically a straight line. Right? They're just moving. It's not actually food. It's a bolus. The bolus is in the stomach. It's moving it along the tube, but in the stomach isn't just moving things along. It's actually churning things up, right? It's like mixing up all the acids, the enzymes, partially digested food. So that oblique layer helps to get kind of some asynchronous contractions going. All right, so gastro just means stomach. There is this fatty skirt in your abdomen called the omentum. Has anybody ever seen bodybuilders that, maybe not bodybuilders, the right word is maybe weightlifter, or a bodybuilder that has, you can see a six-pack on them, right? You can see their abs sticking out, but they still have a kind of a big gut, a little bit of a gut. How is that possible? How is that possible? Well, it turns out that the bulk of that gut that you're seeing is due not to fat that's on the outside of their body that is occluding their musculature from the abdomen. It's part of what's called the omentum. And the omentum, there's two of them. There's the greater and lesser omentum that are attached to the greater and lesser curvatures of the stomach. All right? So the greater and lesser omentum. The job of the omentum is to hang down as a fatty skirt over the intestines, and it serves a number of purposes. Number one, it helps to cushion and protect the abdominal contents, all right, and maybe multiple. Secondly, it provides insulation or barrier. Thirdly, because it is soft tissue, as food moves around the stomach, sometimes your abdominal contents need to shift. Maybe you need a little more room here versus there. It provides some room to move around, and like slightly adjust the contents of the stomach without having like a genuine void space in the stomach. And then fourthly, it serves as a nutrient store or energy. The adipocytes. That's the omentum. The greater omentum just hangs down as a big fatty skirt that covers all of your abdominal viscera. And then the lesser omentum is quite small and forms this aperture on the right-hand side that actually behind it you could go in and palpate the pancreas and various visceral organs that are back there, the pancreas. And you can access the underside, the inferior surface of the liver by going through that aperture. All right. Not going to worry about any of those ligaments. So here's a picture of it. Here it's being cut, and this is the way you see it normally, right? Here in this model, they don't have the measurement. It's been severed along here, but normally it would be this skirt right to show the abdominal, the greater omentum. Okay, stomach lining. Now I have a couple models for the stomach lining. We have one of them here. Casey has one, and then yeah. Oh, yeah. So this is several different stages of the GI tract. This one here is the stomach lining in isolation. So in between these rugae, if you were to look, there are these gastric pits. These gastric pits, a gastric pit is not a substandard diner. It is, in fact, a hole in an aperture in the lining of the stomach that leads down into these gastric glands. And the gastric glands are where we're going to make all the juice that helps us digest it. So the gastric pit has really only one sort of cell up here. These are mucus cells. And then once we descend from the gastric pit into the gastric gland, there's a profusion of cell types. We're going to have parietal cells, there are G cells, there are chief cells. We'll talk about all of those in lecture a little bit. G cells are at the bottom of these gastric glands that it makes gastrin. Parietal cells are where we get HCl, hydrochloric acid, from, and we'll talk about the chief cells as well. So that's all down in the gastric gland. Now, the lining itself of the stomach has these mucosal glands and then this cellular layer of specialized epithelium. So parietal cells, G cells, chief cells, mucosal cells, they're all specialized epithelium. Below that is the connective tissue. Have I used the word lamina propria yet in here? So it is just called lamina propria. And it's just this connective tissue substrate that is the conduit for these capillaries that move up into this mucosal layer. Along with the venules and the arterioles, there are going to be different lymphatic vessels, and we'll see that more in a bit. So the way the stomach works is we have epithelium, lamina propria, and then muscularis mucosae. So muscularis mucosae is a layer of muscle that marks the boundary, the deep boundary to the mucosa. So all of this is considered to be mucosa, the mucosal layer to the stomach. There's going to be 4 layers to the stomach. 4 layers to the stomach. They're going to be mucosa, submucosa, the muscular layer of the stomach, and then the serosa, the peritoneum. The visceral peritoneum, serous. So below the muscularis mucosa, which is the lowest level of the mucosal layer, we'll have the submucosa, and that is again a connective tissue layer that I think it's areolar connective tissue, but it has it's where the larger arterioles and arteries, arteries and veins are going to be running along with the lymphatics. There's a lot of lymphatics in the GI tract, and that is, we'll learn about it more in lecture today, but that's basically because fats are not water soluble. So if you're going to absorb nutrients, the 3 nutrients are carbohydrates, proteins, and fats. Carbohydrates and proteins can get absorbed directly into the bloodstream, but fats cannot, because they don't dissolve in water, and so they actually go via your lymphatic system. We'll see how that works. So that's the submucosal layer. Now there's the muscular layer, and the muscular layer is made of the 3 layers that I talked about. The oblique is the one that's the most inner, closest to the lumen of the stomach. And then followed by the circular layer and the longitudinal. Between the longitudinal and circular muscle layer is something called the mesenteric plexus. Now, when I was talking about CNS, PNS, I talked about there being the central nervous system, the peripheral nervous system, and then the enteric nervous system. And the enteric nervous system is this kind of independent. It touches, it overlaps, but it's fairly autonomous nervous system that dictates and governs the actions of your stomach. All right. So there's this huge plexus of nerves that spreads out throughout the muscular layer and controls the actions of these muscle layers. Mesenteric plexus. And all of this can be seen on that model. And then finally is the serosa on the bottom. That's the peritoneum, visceral peritoneum that lays right on the stomach lining. I know it's like so much, it flies past you. When I first got all this stuff, it flew past me, but with diligent repetition, it will get in there. So, I think, so right up here, this would be mucosal. These yellow ones, I believe, are meant to be, it's labeled. The yellow ones, I believe, are the parietal cells. So what do I have here? It says parietal cell number 9. Is that the yellow ones? Yeah, the parietal cells are marked in yellow. Then the chief cells would be these lighter blue ones here. And then the dark purple at the bottom of the gastric gland. Because remember, this is gastric pit. This is gastric gland. The dark purple ones at the bottom of the gastric gland are the G cells, the gastric cells. Then you're going to have lamina propria up through here. This is lamina propria moving up into this connective tissue substrate. And a muscularis mucosa, a thin layer of smooth muscle that is the bottom of the mucosa. Next is the submucosa with all its connective tissue and arteries, veins. And we move into the muscular layer, the oblique, the circular, and the longitudinal. In between the longitudinal and the circular, on here, looks like it's painted in purple, you can see the mesenteric plexus. And then lastly, this lowest layer, the serosa, periton. So that's the section of the stomach wall. There are some slides. Oh, here's one. What do you know? So in this slide, you can see, I'm sure it turns up better on your laptops or whatever, but you can see some gastric pits that are going to lead down into some gastric glands. So this would be the region of the gastric glands where you're going to have a bunch of parietal cells, and you get down lower. This slide's called them peptic cells, but peptic cell is just a synonym for G cell or gastric cell. They're called G cells because they make gastrin, which is a hormone we'll talk about a little bit. But peptic cell or G cell. And then below that is a little bit of connective tissue, and then we get to the muscularis mucosa. So there's a lot of stomach lining that's not in this diagram. Okay, this is only like that top region of that thing you got there, Casey. But what you can see here are the rugae, the gastric pits. You can see the simple columnar epithelium along here. All right, that's enough of the stomach. So, okay, I want to be done here soon. So, small intestine. 3 parts to it: duodenum, jejunum, and ileum. In the jejunum, we have, so the whole story here is maximizing surface area to volume, right? You want to have as much surface area for absorption as possible within the smallest amount of space. So the way we do that is by having this, again, kind of fractal architecture. I've sort of alluded to the body's ability to use the same structural motif on different size scales to achieve the maximal benefit. Someday I'll get philosophically, theoretically, math, philosophy, and anatomy. But the structure in concrete terms that we're talking about here is the plica circularis. And the plica circularis are totally visible with the naked eye. That's just a photograph, right? So the plica circularis are quite large. It would be the jejunum that had been cut open. You can see these large leaves in the jejunum that helps to increase surface area. So that's a plica circularis. If you were to look closer or feel the surface of it, it may feel like a cat's tongue, like that, because there are all of these villi. These are not microvilli. These are larger than that. A single villi is made up of multiple cells. Each of those cells are going to have microvilli on them as well. So you can see here at least 3 layers of this sort of fractal surface area maximizing motif. So villi are large multicellular fingers that project off of the surface, but still pretty, kind of microscopic. You to really appreciate them, you have to look under a scope. All right. So let's look at here's a plica, and let's zoom in and look at some of these villi. All right. Here's a villi, and we see that indeed it is multicellular. Each of these columnar epithelial cells are going to have cilia or villi on them that are going to increase their own surface area. Under this epithelial layer, there's a lamina propria once again, and in that lamina propria is this capillary network. But also running up into there with the neurovascular bundle is going to be a lymphatic structure associated with each of the villi, and it's called a lacteal, L-A-C-T-E-A-L, lacteal. I guess they drew it green because they lacked teal. Yeah. Just doing what I can to make it stick. Just doing what I can. No. Okay, so, and this lacteal is going to be how the intestines absorb fat. And I think Alan has a nice picture of some villi and with lacteal painted in yellow. Yep, looks great. So what else do I want to? There are different cell types that seems like I'm not going to worry about, so it's like we're not going to worry about it. But now the general layer, the general structure of the wall of the intestine is the same as the stomach. However, with one important distinction, we do not have a oblique layer of muscle. There's no oblique layer of muscle. And where that oblique layer of muscle would be, we're going to have what's called a submucosal plexus. A submucosal plexus. So that oblique layer just kind of peters out and becomes a plexus of nerves. So we have 2 plexuses. We have the mesenteric plexus, which is dealing with the muscular layer of the intestines. But then there's this submucosal plexus, which will send nerves up into the lacteals and are going to help with the neural feedback part of control and regulation. So I'll talk about this in the lecture, but what are the 3 modes of regulation that we talked about? A couple different instances. We talked about neural control, endocrine or hormonal control, and then local control. Those are the 3 kinds of control that we have. There's going to be all 3 of those GI tract. So, otherwise everything's pretty much the same. You're going to have circular and longitudinal. You're going to have serosa, lamina propria, submucosa. So it's all pretty much the same. Muscularis, mucosa. The other thing, rather than call them gastric glands, you wouldn't call them gastric, it's not the stomach. We call them crypts of Lieberkühn, or intestinal crypts. Lieberkühn is a common eponym. I also think about the list. Tell a story about Lieberkühn. But you can see here, it actually looks a lot like the structure of the stomach, except what were rugae are now disconnected and form these villi. All right, so the space between the villi would kind of be like the gastric pits, but it has opened up to this point where there, instead of ridges, there are individual islands. And then at the bottom of that, where you would have gastric glands, we have these intestinal crypts. It's taking gastric pit a step further. Like the restaurant you're went into yesterday was the gastric pit. Definitely do not go into any place called the intestinal crypt. Yeah, it's great. It's great. It would be fun. It'd be fun to have a diner called the Intestinal Crypt. It's like a theme diner. Yeah. Okay. So yeah, all of this is seen right here. This slide kind of has a little more than you need. It shows the actual cellular layer at the intestinal crypt, but I don't need that. Yeah, we just have the lacteal, the villi, the muscularis mucosa, the submucosa. Here is the submucosal plexus emerging. Here's the mesenteric plexus blending in with that as well. The circular longitudinal muscle, and then the serosa at the very bottom. And have fun with that model. Yeah. And don't worry about the Brunner's glands. This muscular layer is sometimes called the tunica muscularis. What can we really see here on this slide? We can see the intestinal villi, these fingers of tissue with the lamina propria in here, the muscularis mucosa. Here's the submucosa, and then just a little bit of the muscular layer would be the circle. There. There must be some submucosal plexus running through there, although I can't really identify it in this slide. Yeah. Okay, so here's a little bit nicer picture. And we can see these columnar epithelial cells. This would be a lacteal. Here's lamina propria. These would be the columnar epithelium, and these little white cells here, those white bubbles, are goblet cells. They're going to be releasing mucus into the stomach. Goblet cells. All right. Onward, upward, or actually downward and outward. So we pass from the duodenum into the jejunum, finally into the ileum. And we get from the ileum, the small intestine, into the large intestine through the ileocecal valve. The ileocecal. I-L-E-O-C-E-C-A-L. I-L-E-O-C-E-C-A-L. Ileocecal valve. So the ileocecal valve connects the ileum and the cecum. C-E-C-U-M. Cecum. The cecum is the first segment of the colon, or the large intestine. And the ileocecal valve is kind of analogous to like the pyloric sphincter from the stomach into the duodenum. Now, the cecum has this thing called the vermiform appendix that you're probably all familiar with, the vermiform appendix. Vestigial structure from when we were more ruminant in nature, and now primarily serves a lymphatic purpose in the body. The colon is broken up into, 5 parts, something like that. There is the cecum, which is the initial segment of the ascending colon. The ascending colon, which goes up to the hepatic flexure is what this is called. I cut that word out. But it goes from the ascending colon into the transverse colon. This is called the splenic flexure, where we go from the transverse colon down into the descending colon, and then through the sigmoid colon. This is the S-shaped part. So So there's 1, 2, 3, ascending, transverse, descending, sigmoid colon, because it's shaped like an S, and then into the rectum, which is the staging ground for feces during waiting for defecation, and the rectum terminates at the anus, the anal sphincter. So a couple other things to point out are that if you look at the colon, it has these sort of like segments, these bulges, these kind of pockets along the way. They're called haustra, H-A-U-S-T-R-A, H-A-U-S-T-R-A, haustra. Each of these segments is called a haustra. And they're sort of linked together with this muscular strip that we call the taenia coli, T-A-E-N-I-A, T-A-E-N-I-A, taenia. I always felt it was a shame that taenia coli is what it is, because it was such a good name for somebody. I liked it. Anyways, taenia coli. I do. I think it's a nice name. No, it's out of reach. It's out of reach. It's off the table, of course. Although my wife was very patient in entertaining my crazy ideas for the names of our children when we were trying to decide. Okay, so this model here demonstrates these various structures. So we have the three portions of the small intestine and then the colon, and you can identify all those right there by Keanu. I'm not going to walk through that slide with you. I've already pointed out all the anatomy, and it's identifiable on each of them. Pretty analogous from one portion to the next. All right, let's end up with the rectum and anus. There's actually more anatomy here than you might suspect, and I'm not going to teach it all to you, but I will teach you a couple things, and specifically the internal and external anal sphincters. You actually have two anal sphincters, two sets of muscles that control the aperture to your anus. There's the internal and the external. And they are quite different. They're actually quite different from one another. If you look at the internal anal sphincter, what do you notice about it? Yeah, it's really just a continuation of the muscular tunic of the colon, right? And as such, what would you guess about the innervation to those muscles? Yeah, it's from the enteric plexus. This is under autonomic control. Autonomic control. You do not have a choice whether that muscle is contracted or relaxed. However, just so that you have a little bit of agency in your life, a little sense of control, there's the external anal sphincter, which is skeletal muscle that is under voluntary control. All right, so you can contract the external anal sphincter, but not the internal anal sphincter. All right, that's the only point I was going to make there. Then the mesentery, and I'm going to quit talking. I think I'm done after this. So the mesentery is another name that we use to refer to a pretty esoteric organ. Like if you are on, Facebook or something, and you see some like sensational article, new organ discovered in the body, and it's really that, I guess, the media somehow caught up to the fact that the mesentery is its own thing and has its own function. This it's not shocking anatomy, but GI tract. But the mesentery is basically the peritoneum, yes, the serosa, but also all of the associated vasculature and lymphatics that run through it. All right, so it's this sheet of serosa that covers all of the intestinal viscera and has this extremely complicated tissue connection. So if you see here, this is the cut edge where the visceral peritoneum joins the parietal peritoneum. Here is through the sagittal section, you can see how it covers all of the different loops and coils of the intestine. And here from the front, you can see how it radiates out from this origin here near the duodenum. So the mesentery itself is just this. You can also call it the mesocolon. It's this broad sheet of serosa and vasculature and lymphatics that spreads out and connects all the intestinal viscera, supports it, helps keep things in place, acts as a service conduit for all of the intestinal contents or components. The mesentery. Okay. Oh yeah, right. I forgot about the liver. Liver is so important. The liver is so important. I felt bad today because I was putting the finishing touches on my lecture, and I kind of completely skipped the liver. I used to talk about it in much more detail, but like the liver is, you can go so deep on the liver that I struggle to know exactly where to stop. So here it is. Here's the anatomy of it, at least. There are 4 lobes to your liver. There's conveniently named right and left lobes, and then there are on the posterior surface. So this is the front. This is the back, not front and back, anterior, posterior. On the posterior surface, you can see the right and left lobe, but there's also these 2 fun lobes called the quadrate, because it's the shape of a quadrangle. It's sitting right next to the gallbladder. And then next to the inferior vena cava, we have the caudate lobe. Caudate because it's a happy liver, wags its tail. It's got, caudate just means tail. Caudate lobe, tail. So keep your livers happy, even on the weekend. All right. There is so the thing about the liver that probably flummoxes most students in terms of the anatomy, there's a lot of plumbing in the liver. There's a whole lot of plumbing. And this is because, first of all, we've got mesenteric, the hepatic, where do I even start? We have hepatic artery bringing fresh blood, oxygenated blood into the liver, so it can stay alive, right? You have hepatic vein that is joining with the inferior vena cava to take blood away from the liver back into circulation. But there's another way to get into the liver through the hepatic portal system. And do I have it on here? Yes, but it's a super bad picture of it. We'll get a better picture. The portal system is blood that's returning from the intestines, is deoxy, wants to get to the heart and then eventually the lungs, right? It wants to go up to the IVC, but it has all this stuff that it just absorbed from the intestines, and it's got to pass through customs first, right? You can think of the liver as customs. It's got to go through there and make sure that it didn't pick up any toxins, or maybe there is a delicious meal waiting to have the best parts of it stored in the liver. So the liver kind of gets dibs, first dibs on whatever's coming back from the stomach. And that's the hepatic portal system. So that also goes into the liver. We'll see how that tubing works in a bit. And then the liver also makes these products. It makes the bile salts that come down through the bile duct into through the hepatic duct into for storage in the gallbladder, and then leaves via the common bile duct. So I imagine that I'm going to have a picture of all that in a bit. There's a bunch of ligaments that pin the liver down. I'm not going to terrorize you with that stuff. All right, so let's look at the liver histology a bit. The liver is a really beautiful organ to look at under the microscope, I think. And this is a cartoon of it, where when you see the liver, there's going to be this. There's going to be a central vein that runs down it, and the bulk of the cells are hepatocytes, the liver cells, hepatocytes. There are a few what are called Kupffer cells that have a support role in the liver. What else do I want to point out? So there are these canaliculi, bile canaliculi that drain bile off the hepatocytes and send them to these bile ducts, which will coalesce into the common hepatic duct. So all of this can be seen here in this slide. So we have a hepatic duct here. Here are some hepatocytes. Wait, did I? Yeah, I guess I didn't have it labeled. But this would be a lobule. This section here would be a hepatic lobule. Yeah, I mean, not a huge amount of things to point out, but this would be a canaliculi along here, these canaliculi. All right. So you can see some central veins, the sinusoids, which are, so they're the canaliculi for draining off the bile, but then there's the sinusoids. So this would be, for example, a sinusoid that helps perfuse the tissue. And then you can see the hepatocytes. I don't know, kind of looks like modern art to me. All right, gallbladder and the ducts. This is going on longer than we have these hepatic ducts, left and right, that come together as a common hepatic duct, which then communicate with this gallbladder. The gallbladder communicates via the cystic duct, which cystic duct and the common hepatic duct come together to form the common bile duct, which is going to come down here and join with the pancreatic duct to form this duodenal papilla. The pancreatic duct is how the pancreas obviously relieves itself of the pancreatic juice. And all of this empties out into the duodenum. We'll see how that comes into play later. So I have all this anatomy up there, but I'm not actually sure if I have a really good model. Oh yeah, it's all here. It's all in the file in that thing. And then the pancreas. So the pancreas is pretty easy. There's a head, a body, and a tail. A head, a body, and a tail. Here's the head, here's the body, here's the it's broken up into several lobules, has a pancreatic duct that runs down the middle of it. And then it bifurcates. There is the pancreatic duct proper continues and joins with the common bile duct, but there is a collateral branch that comes off and goes to what's called the accessory pancreatic duct. And that's essentially because there are times when you need pancreatic juice, but not bile. So turn this on when you need both, close that off, and turn this on when you need just pancreatic juice. Yeah, that's all I'm going to say about that. So this can be seen on this model. Here there's like a relief model there by Haley. A lot of that anatomy. Oh, beautiful depiction of the hepatic duct, cystic duct, the gallbladder, the common bile duct, pancreatic duct, pancreas, body, tail. Yeah, a lot of good anatomy there. And this one as well, the similar diagram on that stand-up model, wherever that one is. Okay, so that's it.